I appreciate you coming, giving up your Saturday mornings, and also acknowledge the traditional owners of the land on which we meet and their custodianship of the lands. So this is an interesting talk for me because normally you talk about your research and all of this, and this is really talking about me. And so we don't get to do that often. And so it's a bit scary, really. But what I've decided to do is tell you what mattered for me and my life trajectory and how bizarre and unusual it was, and how that was a good thing and not a bad thing. So my talk is about the perspective, which is a bit different to most clinicians whose primary role is the treatment of patients or research into an area of expertise in which they become, globally recognised experts if they reach the sort of highest level of their domains. My story started as a clinician. So, and I was thinking as I was a medical student here at UQ and then my psychiatry training here in Queensland, what matters and how can I make a difference? And so I wanted to become, I guess, good at what I did. And these institutions we'll come back to are the ones where they've influenced me and where I have worked and where I work now. The Queensland Centre for Mental Health Research, which is a state-funded mental health research centre based at what used to be Wolston Park Hospital, which is the largest hospital Australia's ever had in patient numbers, well over 2,000 patients at its peak. The University of Queensland and the Institute of Health Metrics and Evaluation at the University of Washington in Seattle. So from my clinical practice as a psychiatrist, and I worked in this place. This is Osler House at now the Park Centre for Mental Health, which is the high security female ward. When I was there as a medical student and then as a psychiatrist and as a psychiatric registrar. One thing I've learned clinically is that we continue as a clinician to see the patients we see, the patients who get referred to us. What we really don't know a lot about is the patients we never see again. Is that a good thing or a bad thing? And I remember once doing an outpatient clinic and we were busy and I had about 20 patients booked in and about 18 turned up, and I sort of was heaving a sigh of relief that I had an extra slot. And my consultant said to me, how'd you go? I said, I went well. They said, any issues? I said, oh, no, 18 of them, 20 turned up. And he said, what about the other two? I said, oh, well, they didn't come. And he said, they're the ones you should be worried about. Why didn't they come? And it may be because they're fine, or it may be because they're not fine. And I've been contacted by patients I've treated, including one in that ward, who had a severe disabling mental illness, was in that ward as a young female, still a teenager. And I really had a pessimistic prognosis about her. And about 30 years later, she contacted me to tell me she was running a major NGO for women who had been abused. She hadn't needed to see a psychiatrist for 10 years. She was off her meds. She got married. She had children. And I was stunned. All the outcomes aren't that good in mental health. But the patients we don't see, we need to remember they matter. But also, not knowing about them also biases our perspective about the population which we treat. So I decided I'd become a good scientist. And after I completed my psychiatry training, I'd worked for a year as a clinician, as a psychiatrist. I took a research fellowship at Stanford University. And I learned lots of things in that year, 18 months I was there. And one of the things that stands out to me was a session we did for an hour every week with the professor of biostats, Professor Kramer. And all we did was look at the methods section of a paper she selected from the New England Journal of Medicine. That was what we did in the hour. Now, as a busy clinician, I never really read the methods section. I read the abstract. She may have selected a biased sample for us, but we, about 50% of, this is the mid-1980s, I was there 85 and 86. So about 50% of those publications should never have been accepted into the journal because the methods failed to substantiate the claims made in the publication. So it taught me to think critically about research methods. And that was one of the many things I learned from that stint. And then I came back to Australia from California, and my aim then was to set up a research centre in mental health. And I'd had that agreement from the Queensland government coming back. What happened was the unit that became now the Queensland Centre for Mental Health Research was funded with core funding from Queensland Health, which exists still today with that core funding, which has grown over time. And it opened in 1987, was then called the Clinical Studies Unit. Now it's called the Queensland Centre for Mental Health Research. The problem with my coming back was that I was bonded, Queensland Health, which meant that they could put me where they needed me. And soon after that research centre opened, I was moved into the central administration of the Queensland Department of Health. I then developed a very depressive episode, I think, or something similar, having been taken away from my research unit and my research. And I was doing administration. It changed my life, that. I never expected, I would never have chosen to do that. Not be a clinician, not be a researcher, what was left to live for. But really I learned about what government thinks about health, what government thinks about health priorities, what matters to politicians, and what they think about is not just how the health system runs and whether people are getting the best treatment. They think about all the people who aren't getting any treatment. And so I started to gain a public health perspective. I dashed off and did an MPH to help me figure out what I was doing and being paid to do. And by 1989, only a couple of years after I moved in, the senior psychiatrist above me had moved on, and I became the Director of Mental Health in Queensland 5 years after I got my fellowship, which was very scary. And Kevin's for an MPH. Healthcare financing, health economics, and health planning, very important things for me. And around that time, 1989, the federal government decided to have a national mental health policy and plan for Australia. We never had one before. The Commonwealth had no mental health branch or mental health unit, and mental health was seen as a state responsibility unless it was Medicare rebates to GPs or private psychiatrists. And in my time in Queensland Health, two other big things happened. The Australian Bureau of Statistics conducted the first population survey for mental health in 1997, found that only a third of people who had a mental disorder were consulted a health practitioner for that disorder in that year. And around that time, the World Bank did the Global Burden of Disease study, which using the Disability Adjusted Life Year, which is now what underpins the GBD studies, and found that the leading cause of disability globally was mental disorders and substance abuse because of the population prevalence. And that really changed how we thought at a public health level about mental health. It's a big public health issue. And in Australia, where we have a national health insurance system, most people don't get treatment. So that really made a big change to the priority that was given to mental health. And then so the first plan was 5 years, first National Mental Health Plan, 1993 to 1998. And it was for 5 years, and that was going to be the end of it. It wasn't in the forward estimates of the federal budget. I was chairing the National Mental Health Working Group that oversaw the first plan from Queensland. In my Queensland position, I was asked to go to Canberra and help get the second one up, the second National Mental Health Plan. And I did. I moved to Canberra and I became the Federal Director of Mental Health. And the task over a couple of years was to get the second plan up. And trying to get things through government policy is basically, I thought that, politics is not science, it's irrational, basically. It's who could ever work out how they make decisions and on what basis they make decisions. But it's not irrational. They make decisions for a reason, like all decisions get made. They're not be the ones you would make. They might not be the right ones, but they're made for a reason. And understanding why those decisions get made and the reasons they get made helps you understand how to get health policy up. And we were successful in getting the health policy up. And the second National Mental Health Plan was funded for another 5 years, and it was put in the forward estimates, and we're now up to the fifth plan. They've kept rolling it out. I don't think they could stop it now. But not in anything being recorded, I can tell you that that was a very close run thing. And the reasons it got up were not what I believe were the right reasons, but they were the reasons that mattered to the health minister, the prime minister of the day and the state. So I think understanding that things which you don't think make sense, but with which you have to work is really important. Because if you understand that and you can align what you think is good science and good health policy with what are the decision-making priorities of another group, including governments and politicians, you can get more done. So I left Australia after that. So what happened then was I'd done a 2-year stint, and I was supposed to I got the plan up. I was supposed to come back to Queensland. And the World Bank, which is the largest lender for health in the developing world, started to lend for non-communicable disease based on the World Health Report in 1993, which used that disability-adjusted life year metric I mentioned. And it started to hire people around cardiovascular disease, cancers, and what they call neuropsychiatric disorders, which is mental health, substance abuse, and neurology. Because for most of the world, the neurology psychiatry split is a Western invention, really. It's the brain, really, and the mind. And it's not a separate entity as far as the patients and consumers and population go. And they wanted to work out how to lend for this neuropsychiatric grouping. And they wanted someone who was a technical expert, they called it, which meant a clinician, and someone who'd run a national mental health program. And wasn't a lot of them around. And even though I'd never worked in any lower middle income country in my life, for reasons which were to do with the politics of the World Bank, which is a Western institution, I was selected to go, and that's the World Bank that's the main building of the World Bank. There's 8 buildings in Washington, DC, next to the IMF, and not far from the US Treasury, which matter actually. And the way that those organisations work. And I went over there and I learned a lot in that. I can tell you, I learned heaps. I learned 2 things I'll mention. One was about what they call human capital. By this time, I'm madly going back to that one subject I did in health economics, my MPH, and rereading my notes and looking at the new notes. But what the World Bank worked out was that for an economically and socially cohesive and progressive and healthy society, you need 2 key things in people. You need healthy people and educated people. And investing in health and education were really important parts of building economically strong societies. And part of being healthy was dealing with the major upcoming non-communicable disease burden, as well as the infectious disease burden, reproductive health, nutrition. So that was the reason we invested. We invested for human capital. It sounds a bit sort of, as a clinician, a bit pejorative to talk about people's health as human capital, but that was the way they thought. So again, picking up, I guess, what I'd learned in Canberra and Brisbane, if that was the deal, then I would work within that system to try and get mental health loans up. And I did. The other thing I learned, I guess, from the bank, which became clear, I guess I'd always knew it, but it really became clear, is the cost of a program isn't how much it costs to roll that program out. The cost of that program is what else you could have done with that money. And that was how they made some of their decisions. So if they're going to spend, and the bank lends between $1 and $2 billion a year for health, and the US dollar goes a long way in Africa. If you're going to ask them to spend $1 million on mental health, the question they ask is, what are you going to do with the money? But what they're really asking is what else they could have done with that money. Should we be, dealing with pollution, or should we look at, insecticide impregnated mosquito nets in Africa or whatever? So that was the question. And so a lot of what I learned then was how to invest in mental health, substance abuse, neurological disorders in low and middle income countries. Because this was my patient's thing. This boy has schizophrenia. He hasn't had any treatment. And that's where he lives. Keep him safe and keep the rest of other people safe. And I thought Osler House was bad at Wolston Park Hospital. If you come from a low and middle income country, you may have seen something like this. What we would call patients chained up, who can't get treatment. There are no meds available at work. And that's gut-wrenching, really, to see that. And I did see that. And no matter how flash my office was in that really flash building in the World Bank, and no matter how many millions of dollars we had, unless we could make a difference to that person, because ultimately I was a clinician. That's what I was trained to do, going to think about the patients. And so I always thought about that. So that's the sort of trajectory. I did 3 years at the bank, then I came back and tried to pick up my life as a researcher. And that was hard. I've been 15 years in government, various parts of government doing various things. But at the end of the day, it was about trying to make a difference at a population level. And my research at Stanford was psychopharmacology and neuroscience. And now I was on a different planet, but the aim was still the same. How to make a difference as a clinician, researcher, being a clinician. So I came back to these institutions where I worked. And so this is what I do now. So I do mainly public health, population health. So for me, I start with how big is the problem in a population. That population can be Brisbane, can be Metro North or Metro South or West Moreton or Queensland or Australia or Southeast Asia or the world. And understanding the size of the problem, what is the prevalence of the disease you're trying to treat and how many of those people should be treated, is the way to start. Not the people who are banging on the doors of ED departments only, not people who are in hospital beds only. Why did they get there? What would have prevented them from getting to an ED department? What went wrong upstream? So understanding the epidemiology, understanding the risk factors, the massive change that's been done by being able to stop smoking or get vaccination programs going. And thinking about that in my area of expertise, mental health. So I took what I learnt about epidemiology and public health, and I tried to measure that. And I'm part of a group, that does the global burden of disease study. My team at QCMHR does all the mental health modelling for disability adjusted life years. That's in the global burden of disease studies, capturing what people die from and what makes them unwell and sick, morbidity, and how risk factors contribute to that. If we're going to do prevention and early intervention. And so this concept to try to understand mortality, morbidity, and risk factors is at a population level for mental health has been really important. And the sort of word I found out working at World Bank and working with IHME, where I have an appointment, and it sounds very reductionistic, but it's probably true in those organisations that if you don't count it, you won't count. And that sort of hung on to me because being able to count the burden of mental disorders did make a difference for my area to how we thought about it. But if those people are invisible, and this is true for any group of people with health conditions, then the people who are most visible are the ones who'll get the services and the other ones won't. So then I thought, okay, well, it's fine to know how big the problem is, but how do you do something about it? Like, how do you get it down? How do you reduce that burden? We did 2 national surveys. We've just done a third for mental health in Australia. The first one done in 97 showed that a third of people with a mental disorder didn't get any treatment. They did one 10 years later, 2007. It showed that a third of people with mental disorders in Australia won't see a health professional for that disorder. The latest one shows we've changed it. But But I remember doing a presentation, I think it was actually at QIMR, and I did this wonderful presentation about about my work and about the National Mental Health Strategy, which I was part of. And I showed that the burden was really high and staying high. And I remember someone came up to me afterwards and said, that's a great, interesting way to present it. We in cancer present our research as sort of how people are getting better, how we're reducing the death rate. We really know what we're doing. Give us more money. You seem to be saying, we don't really know what to do, but please give us more money anyway. And I thought, yeah, actually, that's probably not a good look. I better change those slides. So, so the service system that reduces this burden, this is the National Mental Health Service Planning Framework, which another one of my team leads. And it starts with population prevalence. How many people if we're doing this for Queensland, in Queensland have schizophrenia? How many have, and we know from the epidemiology, we do know this now. And if we don't know for a certain age group, we can model it. And every person with depression is not the same. So there's a severity distribution. Then not everybody needs treatment, surprisingly. There's a demand rate. And then within all those people, there are various need groups that you can come up with. And then once you work out who you're trying to treat, how old they are, where they are, this care profile has, this service planning framework has care profiles. There's 155 in this service planning framework, and from perinatal mental health through to aged care, and for all ranges of severity. And so we say within a year, we estimate how many people in Queensland, if we want to do it, with a major depressive disorder should be treated. And what sort of care should they get in a 12-month period in those care profiles. And that includes medication, psychological treatment, and a range of non-clinical supports they may need. Once you do that, you can work out how much it costs. And so you can run the numbers for Queensland or for Australia or for Metro North or Metro South on how many people have a disorder in that population modelled, what care they need, and what resources they need. And then you can look at the resources you've got now, the resources this modelling says you need, and what is the gap. And the gap, interestingly, is much greater in some age groups than others. It's also different for different disorders. But you know what you're trying to close, what gap you're trying to close. So that's been a way of trying to take that population prevalence and burden data and build it into a resourcing estimate that tells government where we should be going and where the biggest gaps are. And then the last bit is, okay, you've figured out how big population burden is, and you've figured out what sort of service you need. How are you going to get that service up and going? What's the workforce you need? What's the money you're going to need? Which government's going to actually give you those resources? So getting that system in place is the last bit for what I do and what my group does. Remember that bit about politics not always being irrational? I think I left the always bit out the last slide, but sometimes everything's a bit irrational. But I went back to that part and tried to figure out what needs to be done to get more resources into this area. I've got what I think is an evidence base, and I work in that area as well. So this is the Productivity Commission. So the Productivity Commission reports to the Federal Treasurer. Between 2018 and 2020, it did a mental health inquiry, and that meant there were 3 commissioners, and I was one of them. They bring an expert commissioner in. I call it an associate commissioner, and 2 permanently funded commissioners, usually who are economists, but not always. And we worked for 18 months on this study, which is the Productivity Commission, which isn't a health agency at all, on what's the mental health service system look like and why should it receive resources and where. In that report, which was released in 2020 and is still being looked at for implementation. But I was able to do that and contribute to that, partly because of everything that had gone before it. Because I was a clinician, because I worked for government and understood what governments do, because I'd worked for an economic organisation like the World Bank, and because I guess I thought about things that in a way that the Productivity Commission thought about things, or at least I could work with them, which was a challenge sometimes, but the report could be very influential, and it's not a health report. It's actually a report to Treasury. But for me, being able to influence that report was part of getting the system in place that I think the science said was a good system to have. But through all that, for me, it comes back to this. It comes back to that young teenage girl in Osler House, that boy in a cage. Because if I can't change things for them through what I do at the level I work, and even though I've continued to see patients through lots of my career individually, I figure that if I could get the systems right for these people, maybe I could influence the health outcomes for many more people than being a psychiatrist, seeing one at a time in a clinical practice, which is not to say that that's not where the coalface is, but how could I help that and how could I make that better? And so it sort of closed the loop a bit for me to think about, where it ends and where it started. And it sort of did start that loop. Hopefully, that pathway, which I said never was one which I planned. It was never one that I actually even knew existed. But keeping your eye on the goal, I guess, of what you're trying to do, and being willing to be flexible and learn about the things you don't know anything about, and try to put all that together, you can become, have a career, which I guess is different than you might have planned when you're in medical school or as a young researcher. The opportunities just open, doors open and close all the time. Go for it. Just go for it. And you'd be amazed what you can see, what you can do, what you can achieve. And I think if I look back on my career, all of it sort of hangs together. But it hangs together around the fact that if there weren't people with mental health problems, then they wouldn't need me. And if I can make a difference and continue to make a difference, and the staff I've trained will continue to make a difference, then I think the career's been good. I wouldn't change it for the world. Even that secondment into the Queensland Health Department, which turned out to be a really important eye-opener. Thanks very much.
Well, that's absolutely fascinating, Harvey. I hadn't heard that whole story pieced together. So it's absolutely revealing, I think. When you're in medical school, you think your destiny is at the bedside with patients day in, day out for the next 40 or 50 years. So it's really nice to hear these stories of how people take their medical and clinical training and their research training and use it in good ways, in many different ways. So we do have time for questions. And I would really encourage you, because this is a chance to talk to people, and in this case, a leading mental health researcher with global experience. So stick your hands up. One of the things I wanted to ask you first up was, for me sitting there, and I guess for many people in the room, it seems like you've made risky calls career-wise in your decision. You've taken these steps where you didn't know what you were doing, if I can say that. You didn't know where it was going to lead. So what's your advice to people when they're thinking about their next career decision or what to do? And maybe if you answered into the mic would be great.
Yeah, so I think I wouldn't want to say, the audio is still running, I'm sure, so I wouldn't want to say fake it till you make it. But, I was hired with a set of skills, and I could do the job with that set of skills. I could administer a mental health act. I could make clinical decisions of patients that I was asked about. But I realised that to do the job well, I needed skills I didn't get in medical school. I didn't get in psychiatry training. And so I went and got those skills. So I think it's how you can be better at the job that you think you can do, but you could do better. And that's probably true to all sorts of jobs. But for me, they were prepared to take a risk on me. And I thought, well, I've got something to learn. There's heaps I don't know. And this is important. And if it's important, the issue about the politicians was that, everybody votes. And so not just the patients who get treatment, but those patients, the minister telling me this, well, Harvey, most people with mental health problems who are going to vote in the next election, which is what the politicians think about, if they can't get treatment, that's going to be an issue. What can I do about it as the health minister? And how could I help that minister get better population coverage for services? if I didn't have the skills for that, because I only knew about people who did get treatment, then I need to go get those skills and that knowledge. And I did. And I was a better person for it. And I think ultimately I was a better clinician for it as well.
So if I might ask another question, if someone's got a burning question out there, and please feel free. But clearly you've had to do extra training along the way. So you've done your MPH and you've done your specialty training and you've done other aspects of learning. So how do you manage your time? I think that's a key question that people in here want to know. How does a person like you manage your 24 hours in the day? What do you do?
Yeah, well, I do 1 day a week of clinical work at the moment, and I do 4 days a week as a researcher. And for me, I guess I prioritise the things that in my day-to-day work that only I can do. And that's a very small wedge of things. Most of my staff are much better at doing various things than me. And I just let them, I let them go. I think picking good people to work with is really important, really important. And I was told once by a senior consultant that I worked for, Harvey, this is when I was in Queensland Health, Harvey, you've got one skill. And I thought, yes, I'm a good clinician. The good skill he thought I had was I could pick good people. And I think he was right, because a lot of my success is about my team, seriously. There are 5 high sites, if you know what they are, at QCMHR in mental health. 2 of them are women in their early 30s, and that's not bad. And those 2 women were hired with honours degrees from psychology at UQ. They are superstars. One of them leads the Global Burden of Disease team at UQ and also at IHME, even though she lives and works in Brisbane. And she's the only team lead for a thematic group of disorders that's not at Seattle. And I don't know how that was. Maybe that's something you can't really learn or teach, but the team you work with is really important. And I was lucky in Queensland Health and the Feds, the World Bank, where I work now. I'm surrounded by good people. If you can find that environment, find it.
Can I ask you another question? And there's no right or wrong answer to this, obviously, but a lot of people ask, do I have to do a PhD after my medical degree to be a clinician scientist? So I'm interested in what your experience has been, particularly in the mental health world.
Okay, so does anybody know what my PhD is in this room? What do you think it's in? It's a good guess. My PhD is in political science at ANU. Not what I'm known for, but that third link on the chain about how do you get things up and running and funded. That third bit, I was heavily involved with the National Mental Health Strategy for a long time. And I thought through how we got things done and why we didn't get other things done. And there's a whole, it's not irrational. There's a theory around this. Political scientists study this. And to do that last closing of the loop, I decided that would be my PhD. And that was done later in my career. So was it important to have it? I think it sort of matters. If you do a PhD, it's not about the perception it gives you. It's not what the content of your PhD is. It's what people think you had to do to get it. It's hard to do. It means you drive hard, you work hard, you complete difficult tasks, you manage it, given everything else in your life, and you finish it. And you've got analytic skills, and those are what people are after, not the content of your PhD necessarily, but what it taught you to do. So I think that matters. The second thing is do it on something you're interested in, then it's easier, something you're passionate about. And that's what I did. I went to Canberra. I was living back in Brisbane at the time. I went to Canberra and got my supervision there because that was the School of Government, Crawford School at ANU. So yeah, that's why I did it.
Terrific. Okay, surely there must be some questions. Here we go. Hands are going up. So 1 and then 2. Yep.
Yeah. So with regards to overseas fellowships, do you think that was a good thing for you to do? Do you think be useful, and in what sort of things do they look for?
Yeah, I had a Queensland government scholarship, which may not exist anymore, that sent bright young doctors overseas to get skills they need, and I was fortunate enough to get one of those. I think it depends on the funding body and what they're going to ask for, really, and what they want. And so that might be a niche area. What Queensland wanted from me was to bring knowledge and skills back to Queensland that they wanted to have. The person who did it after me went to the Institute of Psychiatry in the Maudsley in London and did forensic psychiatry because they wanted to do that. So thinking about what the funder wants, I think, is important. Do you have to go overseas? No, you don't have to go overseas. But for me, moving into global health, which I did, that was pretty important. So yeah, it's a bit of horses for courses with that.
Okay, and there was another question, I think, as well. Yeah. So we might just repeat the questions. I think we are recording and it's not always easy to pick up audio. So the question was really about how do you resolve the tension as a clinician, giving advice to a government who might make a decision that differs from your advice? Is that essentially what you're asking? Yeah, so how do you manage that tension?
Yeah, I think, so in this world that I work in, perfect is the enemy of the good. And so if you strive for perfection and that's the only thing you'll accept, then you might not get anything done, really. So I've had examples where we've been asked to provide advice to a government on the most cost-effective intervention for young women. And there were multiple options put up, programs to decrease cigarette consumption in teenage girls, or increased, screening for cervical cancer or breast cancer, a range of things. The one that was scientifically the best of all the ones put up was programs to stop teenage girls smoking. That didn't get approved. Breast cancer got approved because Kylie Minogue had just had breast cancer and it was all over the papers. So the political win for the government and the minister was to fund something that the public saw was a really big priority. It wasn't the most evidence-based one. And for the minister who made that choice was rational, even though it wasn't the choice that we recommended. And so you live with that, because at least you understand why it was made. And I think that is about problems that are big health problems but are invisible, need to be made visible for a broader understanding of why you would put resources into something. Having lived through a career, when I went into mental health and I went from a paediatric training program at the Children's to a psychiatry training program at the Royal Brisbane, a very senior nurse who I respected greatly said to me, "What a waste of a good doctor." And that told me something about the specialty I was going into, and the way it was perceived in the profession that I belonged to, the health professional. And that was something about the patients I was going to treat and the population I was going to try and help. And if they're invisible, if that's the way a very experienced senior nurse thinks, then we need to do something about that. And that's the truth.
One last question, sorry, and then we can, you can definitely speak with Harvey at morning tea time. You'll be here for morning tea. So we'll just hold off one more question and then we'll wrap up. So yep, up the back.
Yeah, you mentioned picking good people with good, just personal characteristics-wise, what exactly do you look for, and how do you pick up on those things just from like a resume or a personal letter? Or...
That's a very good question. And I think you can do all the standard things. You can look at, their academic scores, you can get referees, you can do all the things that our HR program will give you. I don't know, I think, and maybe this is completely wrong, but I am a psychiatrist and I was trained to understand a little bit about how people think and behave. but I get a gut feeling with people. And maybe that's over time, experience or whatever. And I can't quantify that. That's not a quantitative thing. You get a feel that someone cares and someone is passionate. And it's not about how bright they are or what their scores were at university. Both of these two women I spoke about were bright, but they weren't top of their class. So yeah, I can't actually help you with that. Don't do psychiatry training, just try and get it, because you probably won't. Because I don't think they teach it in psychiatry programs either. But it is about whether you feel someone is passionate and works hard and they care. Because for me, mental health is more than a job. It's about, my identity a little bit, really, and what I want to be, what I want to think at the end of my career. Did I do a good job? Are people better off? And if I can say yes to that, then I've had a successful career. And my clinician skills and my scientific training have been critical in that. But this thing about your gut feel or your intuition is sort of like part of who you are as a human. And if you can channel that, and you make mistakes, I've made mistakes in who I've picked, but you learn from that. And that extra thing, it's like as a psychiatrist sitting with a patient, and the patient has been seen for an attempted suicide. And the question is do you admit this patient to hospital or don't you? And if you admitted every patient who had suicidal ideation and self-harmed, all their beds would be full and there wouldn't be any room for anybody else. You make a call about whether to admit that patient or whether to treat them as an outpatient and send them home. And a lot of that call is made on, quantitative clinical skills, but the big call is made on how that patient made me feel as I was talking to them. And that's something I listen to. And I've got better at listening to that. So don't just be a quantitative scientist, which I'm assuming you're going to be, or bright people, which you all are, otherwise you'll be sitting in this room, but who you are as people, and get in touch with that bit, because that matters too. It really matters. It matters there. It helps keep your eye on the ball.
Well, that's a great note to finish. Please join me in thanking Professor Harvey Whiteford for an outstanding presentation. Thank you, Harvey.